Well, hi everyone. Surprise, I'm not the speaker, but I'm here to introduce the wonderful team at Blue Cross Kansas. My name is Thamra Subramanian. I'm the Health Equity Director for Healthy Blue Kansas, which is an alliance managed care organization. So we serve the Medicaid members in the state, over 100,000 Medicaid members, and we're the newest MCO in Kansas. So over 100,000 hands-ins that we serve, and the majority of them are kids. And so that's something that makes us a little bit unique and also has changed our perspectives a lot, especially in the context of my work in health equity and trying to improve disparate outcomes in children. We have a lot of network providers, and those are a big alliance between us and Blue Cross Kansas. And something that sets us apart is we have a really robust housing and employment program for Medicaid members. And we've learned a lot from Blue Cross Kansas and all the work that their health equity team and Healthy Blue Initiatives team does. So it's very exciting to be able to introduce them. So today we're going to have Sonia Jordan, who is basically my counterpart at Blue Cross Kansas, present most of the stuff today alongside with Virginia Barnes and Amy Jantz. So they're going to be sharing a lot about what they do to actually measure and track health disparities, which is very, very hard. So that's something I'm looking forward to learning more from them on as well. Sonia and her team have years and years of experience in public health and health equity and have been able to transform what they've been doing on the ground with COVID response, emergency preparedness, and more to action. And we're really excited to hear what they have in store today to share. So, Virginia, do you want to take it away? Also, Healthy Blue has a table at the resource fair if you want to go check it out. I was supposed to say that. Our wonderful colleagues there can give you more information if you want to learn more.
Thank you so much. Okay, let's see. So I first I'll say good morning, and I'm happy to be here. I think one of the great things about having the Healthy Blue team is it really expands the ways that we can partner across the state as Blue Cross and Blue Shield of Kansas. One of the drawbacks is that my area is called Blue Health Initiatives, and Healthy Blue and Blue Health Initiatives are not the same thing, and so it confuses the heck out of everyone, but it's great to have some of those opportunities to make that distinction. And so we are part of Blue Cross and Blue Shield of Kansas, and our Blue Health Initiatives work looks at community population health and prevention across the state. And so I will just kind of give a little of the high-level context of our health equity work, and then invite Sonia and Amy to really dig in and talk about some of the more specific work we've done for maternal health in the last several years. So I think the important part to focus on with health equity is it's the marathon, not a sprint approach. And so it really truly has been a journey for us to get this up and running. And so in 2021 was when Blue Cross and Blue Shield Association really launched a national health equity program, and we at that time recognized that this was a real opportunity and a gap in what we were doing. So we were very excited to have some of that support and capacity from the association level nationally, and Blue Cross Blue Shield of Kansas went ahead and took that leap. So we have not been around long in terms of the health equity program, but we are making progress. I really appreciated these cards. So this morning it said, if you could design the perfect equity-focused data system, what is one feature it would have? The demographic data, which we didn't have. That would be one feature. And so that was probably one of our biggest challenges, is that, historically, as a largest commercial health insurer in the state, people's demographic data was not information we collect. And so when you're trying to do deep dive analytics on what are the gaps in care to improve health equity, and you don't have demographic data, that's a pretty big challenge. And so that was really a lot of where we initially focused our work, was how do we do a good job of setting up a system to let people self-report their demographic data and be able to make that, optional, make people feel safe and comfortable submitting information, and ensure that we could then have all the protections in place so that we can use it only to fill gaps in care and make health improvements. And so we did a lot of really detailed work there. The other piece of that is that in the meantime, we sort of got to that point this year where we could actually have our members self-report their data. So in the meantime, we also needed to have some tertiary data so we could actually get moving and start to understand what the analytics we could do. So we were able to work with Blue Health Intelligence to kind of get a tertiary data set that gives us an idea, a likelihood of what our member demographics are for race, ethnicity, and language. And that gave us a start to get a sense of what our membership might look like. So we've had to do some supplementing along the way to get some analysis going. So that was kind of a big key part of getting launched. And then the other piece that I would say is this was also in tandem and an effort that helped us with building out more around our population health management team. So our health equity program sits under the Blue Health Initiative area. We actually report up through government community relations, and so we wanted to make sure we were working really closely with our health analytics team and with our medical affairs team to understand what are the data needs of our members broadly, and how do we start to make sure people are asking health equity questions along the way to ensure we're building good programs in the future and really considering our membership and not leaving, again, gaps in care. And so we've been able to, we've been able to partner internally to really align our health equity work with our population health management work. And again, I think we'll go into a little bit of that in terms of what that looked from an accreditation process. And then the reason it sits under our Blue Health Initiatives team is that we also wanted to lean into our external partnerships. And so we do a lot to ensure that we can connect with stakeholders across the state, understand what are the needs in our communities. And we serve 103 of the 105 counties in Kansas, so we are mostly statewide, and we want to make sure that we're understanding what does it look like in Topeka, but also what does it look like in Colby or Garden City or even our most frontier communities, and how do we help get those partnerships into our really rural areas too. So we'll kind of talk about what that looks like as well. And then I think another thing we thought was important, not maybe the most important thing, but an important part of it was actually really having a commitment statement. So what does our health equity program stand for, and what does that mean at the company level? And so we did take some time to put this statement together. I will not read it to you, especially because it's behind me. But I think, we didn't want to put this out as sort of, look, we believe in health equity, and sort of slap it up like that. Like, look at this company. And we are a not-for-profit mutual health insurance company. We wanted it to resonate with our members, with us, with our communities. And so we did take some time to be very intentional with that statement. And then I threw this into, I probably should have put these in a different order, but I wanted to show too with the population health management side. We are doing a lot on the health equity demographic data analytics piece, but we're also really building out some dashboards around the chronic disease and prevention pieces. And so we've really been excited because the work that Sonia and Amy are going to talk about has been a really, really nice use case for us to start thinking bigger across the company and really understanding what are our most costly conditions and what are our biggest areas of opportunity to really fill those gaps and think more creatively. And so we've started to really get some good data dashboards and work more closely, again, internally with our health analytics. And so just kind of want to share that this feels like it's really just the beginning, and we're really excited to be here to begin our journey. And we are just starting and hope to continue to do more. So if you hear something you like and you want to partner or connect with us afterwards, please do. All right, I'm going to send the mic over here to Sonia. Oh, please. Yeah, absolutely. Go for it. That's my favorite kind.
But when you say these partnerships you establish, what's an example of a partnership in this space?
Yeah, so we're actually going to talk a little bit, but I will say we try to partner, on the academic side. So if there are evidence-based programs that already exist, we're not going to recreate it on our end. We're going to try to boost those partners that already exist. We try to partner broadly in our pathways to our Healthy Kansas work and our Blue Health Initiatives work. We partner with community partners, community health coalitions, local health departments, local non-for-profits. So we try to keep a pretty strong network across the state. Again, they'll go into some of the details from the healthcare perspective and some of the other partnerships at the state level that we've worked with too. But if you have questions afterwards, ask another one. Right.
Okay, good morning, everyone. This is going to be a challenge for me because I'm a wanderer, and so sticking to a mic is going to stretch myself here a little bit. So this is probably not new information for you guys, I'm guessing. I'm guessing most of you in the audience have seen a version of the difference or of how to explain visually health equity. This one is from the Robert Wood Johnson Foundation if you're looking for it, so you can go to their website and grab it. They have a ton of great graphics there. But what I really like about this one is in the right hand you can see the curb cuts and the signals. And what I love about this is that curb cuts really are something that are designed for somebody who needs access in a wheelchair. But curb cuts are what we consider to be a universal intervention. They're something that even though, I might not need it, I like having a curb cut. It's a little bit easier. If you're older and use a cane, or if you're a kid on a skateboard, or a mom pushing a stroller, these are all things that make life a little bit easier. So while the intervention is specifically designed for somebody in a wheelchair, it's applicable to a wide variety of audiences. And this really spoke to me because that is the work that we're trying to do. And as I get into our maternal health program and talk about some of the work that we've done, you'll see how a lot of our interventions are designed to target people who are highly at risk for a severe maternal health outcome, but also has the perspective of like a rising tide lifts all ships. So it's designed to help everyone in that community. So I'm going to go through our maternal health program and how we've designed it and how we did some of the analysis of it. And then when we get into our specific interventions, I will be turning it over to Amy. Is that right? Okay. So before I get into the maternal health program specifically, these are our 4 areas of focus for our health equity program: maternal health, behavioral health, cardiovascular disease, and diabetes. We're actually looking at more than just that. For example, we're looking at rural health. We're also looking at language access and accessibility within our Blue Cross organization. But those are the primary areas of health focus. Also, I'm sorry, I feel like I'm very loud for how tiny this room is. So I keep kind of pulling myself back here. So these are the guiding principles for our program. So, let me move the mic here. So we want to use data effectively. We want to have interventions that are data-driven. We don't want to throw a dart at a wall and hope that the intervention that we're picking is going to make a difference. And as Virginia alluded to earlier, and Thamara actually, the data side of things is actually quite complicated at a health insurance company. This was new information to me when I started. I thought health insurance companies had a huge amount of data, but this is not always the case. We want to identify initiatives that can be scaled effectively. So a lot of times we might start with a pilot and then expand it out, for example. We obviously want to work to improve health outcomes within our membership, but also within the communities we serve, whether they're members or not. We want to lean into partnerships at the community level, so we'll give a couple examples of what that looks like today, but again, if there's further questions, we can get into that more. And Virginia would actually be a really good person to talk to about that. And then we want to influence health policy at the local and state levels. So this is kind of how my brain works in terms of completing a public health project. But this is actually an incredibly common public health model. So when I have to look at something like, okay, we're going to work on maternal health. Well, that's a pretty big area. And how do we focus that so that we're going through the steps in an order that makes sense, so everything is consistent and cohesive? And so we kind of laid out this model that helps guide us through the projects that we do. So we want to start with research. We want to research what the issue is. What is occurring? Is this an issue within Kansas? Is it a national issue? Does it make sense for Blue Cross to pursue this as an initiative? Then we want to look at the data. So maternal health is a great example of this. We knew that maternal health, as many of you in the room probably are aware, was an issue of rising importance at the national level and at the state level. But what we did not know was whether it would be considered a quote-unquote problem within our membership. And so we had to identify, is this an issue for us or not? Is it an issue that, as Tamara said, you know, they're the MCO in the state, we don't serve Medicaid. Maybe there's enough of a differentiator there that this is not a huge issue for us. And we'll get into what that looks like. And then we want to prioritize the evidence-based interventions. As Virginia said, we don't want to just come up with something or reinvent the wheel. We want to know that the interventions we're selecting are evidence-based to make improvements. And then we will implement those at our the Blue Cross Blue Shield level, and then we will integrate it into a cycle of continuous quality improvement. All right, so I'm going to go through that model in a real-world example with our maternal health work. So again, this is probably not wildly unfamiliar to you. But we knew that maternal health was an issue of both Kansas and U.S. public health, a rising public health issue. We knew that there were known health disparities, that Black women and Hispanic women had higher rates of negative outcomes. As I said earlier, we did not know the extent of the problem within our membership. We knew that they are typically considered high-cost events, and that it was a Blue Cross Blue Shield Association priority area. So that was kind of what the research was telling us. And then it was time to dig into what the data said. So we worked with our health analytics team to kind of identify some basic questions to guide their work. So what we wanted to know, basic question, does Blue Cross Blue Shield of Kansas have an issue or a challenge with severe maternal morbidity events or not? And if so, what are the priority populations, and are there any disparities occurring? And what is the cost associated with the SMM events compared to the non-SMM events? So this is the information that we gave our health analytics team. When did we meet with the health analytics team to do that? Probably like not that long after I started. So I want to say maybe like 2 years ago. It was about an 18-month journey to get to the answers of some of those questions. So everything is presented nice and neat in the presentation today, but just know that there was a lot of ups and downs, and that's very normal. So if you're kind of feeling like you're in a little bit of a valley of a data project, like that's a totally understandable part of the journey. So we worked with our health analytics team to identify the model and the methodology for how we were going to answer those questions. This fun kind of graphic here in the bottom right corner, hopefully you all can see it, that is every single relationship that exists between every single variable of what they analyzed. So it probably looks just like a gray blob to you in the background, but if you came closer, you could see that they all like intersect and form this like really cool graphic that I always describe as an adult coloring book graphic. So, but that is the work that our health analytics team was doing. So the preliminary results. So we found, perhaps unsurprisingly, that we did have a problem. So we had a rate that was only slightly lower than the state of Kansas rate at the time of delivery, and then we had a slightly lower but still present SMM morbidity rate at postpartum time. So we discovered, okay, that's good. That answers one question. We're able to identify, yes, this is worth us pursuing with our membership. But the lack of data led to a lot of challenges. We had large percentages of unknown race and ethnicity data that made it impossible for us to say with any confidence whether there were disparities occurring. And the SMM events were rare in our population, so even at that rate is still quite small compared to something like type 2 diabetes or cardiovascular disease that you would see in a population. So you're really, by the time you're kind of slicing and dicing, looking for disparities, your numbers are really small, and that doesn't give you a lot of statistical power to work with. So I want to do just one small detour here, if you'll indulge me, and Virginia alluded to this earlier. So initially, when I first started, we didn't have the capacity to collect directly from our members their demographic information. Now, typically, this is pretty surprising to people, and it was actually surprising to me, even though I've signed up for health insurance multiple times. I was trying to think back in my memory bank, like, have I ever put my race or ethnicity down when I completed my health insurance form? I was like, surely I have. But we actually don't collect that information. And so we worked with our Blue Access team, which if you're a Blue Cross and Blue Shield of Kansas member, you have access to a portal that processes your claims. You can check whether a provider's in network. And now, as of July 2025, you can report your demographic data into the module. So, I know, thank you. I appreciate that. It was very exciting, especially in 2025. At the beginning of 2025, in January, I was like, there's no way we're launching this project. But we did, and it was so exciting. So here is our little flyer about how you do that. If you're a Blue Cross and Blue Shield of Kansas member, please come grab one and consider putting this information into the Blue Access portal. It really does help us, and we do get a small trickle of data every day. I bug our health analytics team all the time about how many people have submitted this data. But this allows us to hear directly from you on your demographics, because right now, as Virginia says, we use an algorithm, and it's actually pretty good, but it's not perfect. It's not the golden rule. So please come grab these. If your organization uses Blue Cross and Blue Shield, feel free to take a bunch or a handful. So I talked through a lot of this, but basically if you log into Blue Access, there's a demographic information in your account, and you can just go through and put that information there. All of the questions there are not required, so if you don't feel comfortable answering one of them, you don't have to, and that's the same with anyone that would be putting that information in. And we're actually building it into our mobile app as well. So a lot of good progress in that area. So back to the preliminary results. So another thing that we were able to determine from that initial analysis is that these are high-cost events for our company. So I didn't put it in here, but we have a bunch of dashboards now that show all sorts of stuff. But one in particular shows the prevalence of a condition compared to the per member per month cost. And if you look at the prevalence of SMM, as I said earlier, it's very, very tiny compared to like cardiovascular disease, asthma, behavioral health. But when you flip to the cost graph, almost everything flips. So the SMM events are extremely costly events for the healthcare system. So any SMM event on the far left is roughly $6,000 more than any non-SMM event. We also discovered as part of this analysis that those are not one-time costs, that they extend for the mother, and they extend for the child as well. So the infant is likely, if they're born during an SMM delivery, they have high costs too, and those high costs continue year after year after year. I think we finally stopped looking at like year 10, and we were still seeing higher costs. And then we found out that we have a lot of SMM events in our urban areas and our rural areas both. So that was kind of a unique finding. The semi-urban area was the only area with low events for us. That was interesting because a lot of times in the literature there's this divide of it's an urban issue, or there's a rural issue because there's lack of access, or there's an urban issue because of the demographics there. And what we found is for us, it's both. And so it did not make it easy for us to say, oh, we're going to focus only on rural healthcare or urban healthcare. So we returned to the analysis because we really were missing that disparity piece. And what we did is we worked with our health analytics to identify the risk factors that lead to SMM events. And so they're here in this box here on the right. And basically what we decided was, okay, these risk factors, things like anemia, asthma, higher BMI, gestational diabetes, these things are a lot more common in pregnancy than the SMM event itself. So that should give us more numbers, and that should give us more statistical power to make some determinations here. And so the lesson we learned here was just to be adaptable and adjust as needed so that you can get the answers you're looking for. So our expanded analysis was able to add some nuance. So for example, anemia here in the top, the dark blue line is 2018, the orange line is 2023, and the light blue line is the 2026 projection. First off, it had not risen to me in my research that anemia was a high priority issue. And so we were able to identify for our members it is. Since doing this presentation a couple times, I've heard from other people saying, yeah, it is for us too. This is actually something that is like not as well studied. And it's only going to continue to rise. And we see here that a lot of our risk factors are going to continue to rise. So gestational diabetes and delivery BMI of over 40 are also expected to rise. And then we were able to find out that there are some significant relationships by race with different risk factors as well. So for example, in the second row, we see that Black women have a 17% chance of increased likelihood of anemia during pregnancy. And white women on the bottom have a couple of significant relationships as well, but the numbers are quite smaller compared to some of the other numbers that you see. So in particular, that 17% one is high. For gestational DM, which is gestational diabetes, for Asian, we also see a quite high number, about 14% here. So we were able to start to kind of understand what was happening. We worked with our communications and marketing team to develop data products to tell the story. So, more promotion here. But feel free to come up and grab these, whether if you're interested in the material, that's great, or if you I like also just having samples of things like infographics to look at for inspiration for my work. Feel free to come grab these, but we worked with our health analytics team our communications team to figure out how can we tell the story in a way that you do not have to be an epidemiologist or you do not have to be an OBGYN. You can just be a person in a community who can understand what this data is saying. And also within our company, we have a broad area of expertise within our company, but we needed them from all sorts of levels to be able to understand why this was an important issue. I'll also put a plug in for our health equity website where you can see our maternal health report that we have there. And so then we got to the step of identifying data-driven interventions. So I'm not going to speak much about the Blue Distinction Centers because Amy's going to go into that. But I am going to talk a little bit about our model to identify high-risk pregnancies and our partnership with Baby Talk. So our model to identify high-risk pregnancies, some of you may be familiar that there's a bundle reimbursement system for labor and delivery. So a lot of times the cost is bundled together and submitted after the delivery. That works well from my understanding. What it doesn't work well for is being able to identify high-risk pregnancies early because you don't actually know somebody's pregnant until they've delivered. So that makes the intervention challenging. So we worked with our health analytics team, and what they've done is they've gone back into the history of claims, and they've pulled what they think are going to be significant indicators that somebody is pregnant. And then we gave them all of the information that we think makes somebody high risk. That is the actual like healthcare issues that we think make you high risk, but also things like neighborhood, poverty level, that sort of thing. And what they're doing is they are developing an algorithm to be able to predict who is pregnant earlier by 20 weeks of pregnancy. Then we can filter by high-risk pregnancy and be able to connect them to our wellness program for maternal care. So that is the plan that we are working on right now. And I met with our health analytics team yesterday, and he said the model should be done by the end of November. So that is really great. Sir, you asked about some of the partnerships we do. This is one that I can't take any credit for, but I just love this program so much. We're a sponsor of Baby Talk out of KU Wichita Pediatrics. We were able to expand the number of spots they offer so that they offer spots not just out of Wichita, but hybrid for the entire state, whether you are a Blue Cross Blue Shield of Kansas member or not. So we sponsored these classes. They're free. They're totally free. There's 6 prenatal classes. It's an evidence-based program. It's available in Spanish and English. It's available virtual and in person. When you graduate, you get all sorts of prizes and goodies. You could get a car seat or a pack and play. And so there's a lot of, and it's really about partnership and about collaboration with the Baby Talk program, because we just try to work together to basically promote the program as much as possible. And every time we reach out to them and just assure and confirm, like, we're not overwhelming you, they're like, bring it on, we want more and more and more. So we're pursuing even more promotion with this program. Unfortunately, you guys are going to be shocked, I forgot the Baby Talk flyer. So, but if you're interested in it, feel free to email me. I will email it to you. And then finally, I think this is, Amy, this is your warning that I think you're coming up. We integrated this project into our quality management committee. And this is an important part of our accreditation that Virginia mentioned earlier. We're the first payer in the country to be accredited through URAC for health equity, and part of that was assuring that we have a quality management component to our program. And so our maternal health work is a quality improvement program. We have dashboards built out so that we can monitor how we're doing with all of our measures and our metrics, and we review them with our clinical quality team. We meet like every other month. And so we've been able to integrate into this kind of cycle of continuous quality improvement that not only allows us to assure that we're doing what we said we would do and plan to do, but then also allows us to share the work we're doing across the company, which is how we got connected with Amy. So let me just make sure. Yeah, okay, you're up.
Hello, I am so excited to be here with Sonia and Virginia. My trade is nursing, and I have a lot of experience in maternal health. I worked at KU Med Center in the high-risk OB clinics there, and then I've also worked in the floors on different hospitals, both rural and larger facilities. So I was really excited and happened to catch wind of this maternity project that was happening. So I joined Blue Cross Blue Shield in the first part of last year. And so the beginning of 2024, I guess that would be. And it didn't take me long to track down Virginia and have coffee with her because what they are working on is such a passion of mine. When you start looking at the data, it's exactly what Sonia had said. You don't want to be throwing an arrow and hitting the dartboard out of, just blindfolded. So you have to collect a lot of different things, and sometimes getting that information is very difficult and challenging. How do I?
Oh, sorry, I don't have a table. It should be yours.
Okay. All right. So how I got involved was the association had identified us as a plan that could potentially impact our Blue Distinction Centers. And we have Blue Distinction Centers that are outlined from the association. So this is coming from a national perspective, and the information that's being looked at is from a national level. So I had said, well, I have interest in kind of sitting in and listening and seeing what this is all about. And before I knew it, I kind of jumped in and said, well, sure, I can help with this. So as Sonia was saying, Blue Distinction Centers really promote high quality, safe, cost-effective care. There is on the Blue Cross Blue Shield of Kansas website the actual criteria for qualifying for that. Well, at one point in time, we had a lot more people qualifying for that than we had more recently. So therein lied the project right there. How can we get some of these people back on this? And a lot of things had changed. So you can either have the Blue Distinction Center of Quality, it's quality care, treatment, expertise, better patient results, but then you can have the plus. That's the only difference there is the plus. And that really adds something, because that adds the dimension of affordability. And that starts putting in to the picture how are these distinctive programs. It's just not a certificate hanging on a wall. I was a nurse in a lot of these facilities, whether it was in a rural area or in a large urban area. And I was always very proud to see that if that center that I was working at was a Blue Distinction Center. So here are areas of specialties in that. There's maternity care where we focused. Spine surgery is a big one. There's all kinds of different ones, bariatric, and I believe hip and knee is also a good one that a lot of people strive for. So why would we think that this is something important? Like I said earlier, we wanted to really look at how this would benefit our members and how the things that we were identifying impact cost or could be looked at earlier, like Sonia was saying. So when we looked at it from the maternity perspective, our data showed that when you look at it, the maternity BDC programs had a lower rate of cesarean births, episiotomies, elective births, and lowered median cost of births even by about $1,000. So that means that it's not just a certificate, it means that those facilities are doing something different. They are focused on certain criteria that is outlined, and when you get that certificate through our organization, then you are one of those that are saying, we really recommend this facility because they're providing really good care. Now, to say something else in regards to that, I have worked in facilities that aren't those distinction programs, and some of them are very close to being able to be those distinction centers, but I'll talk to you a little bit more about the challenges in that. Let's see. Oh, it also, our C-section rates, we were able to compare that, and that was at 13% rate compared to if it was a non-BDC center, 20%. You can see that's kind of significant there. And episiotomies, that's a big difference. Elective births, also a pretty significant difference there. So what we did was we started looking at all the people. How I decided to go about looking at all this is I compiled all the data from the people who had all applied. And because that comes to us in a PDF form, and it did not convert nicely when I converted it to an Excel file, I had to manually type in every single question that's asked when these people apply and enter every single person's response. So I took the group of people we had and compiled that information. Then I started looking at who had it 1 year prior, or it was 2023, right? And then who doesn't have it now, and why is that? But the association did come in and redefine a lot of stuff. So they decided they don't want to just hand somebody a certificate and say, you're doing a really good job at, your maternity, and we're just going to give you the certificate to hang on the wall, kind of like a participation certificate. No, they redesigned and mapped out their whole entire plan. So that became a little bit harder because anybody who's in rural America knows that people wear more than one hat usually at a small facility. And so this made it really hard because you don't really know what you're doing to not meet that criteria anymore because you were before and now you're not. So we went ahead and looked at all these different things. The benefits to our facilities that would end up with these would have the following benefits here: cost efficiency, better patient outcomes, and like I said, it's looked at from a national perspective, and we just focused on our state. So some of the examples of this requirement is that there's a quality improvement program established, that they have accreditation. And that is sometimes where some people end up having a little bit of a problem because some of these smaller facilities aren't always interested or have the means or abilities to be accredited. Proper protocols, collections of demographic data. That was one of them that I want to point out and connect to what Sonia was talking about before. Because without that information, you're not able to link some of those things together. Sorry. Drills and exercises, elective delivery rates, and cesarean rates. That got people quite a bit. Thank you. Yeah.
Quick question.
Yeah.
Following up on my partnership question. Collection of demographic data. I would assume that that was coming from partnerships that were established, but clearly it wasn't.
And that's really interesting you brought that up because I'm going to kind of, go the direction of your question instead of the slide here. It's very interesting because what Sonia also was able to identify through a lot of her work too is that and I identified this as a nurse working out in the communities and from doing registration before I was a nurse. You can think you know somebody's ethnicity or their background, but you might not know. And in small towns, that happens a lot. And people are very offended to be asked, so a lot of people don't ask. So what happens is you don't get accurate data. And so by having this ability to register this yourself or however, you're going to be able to increase your ability to associate different things with the correct information. So a lot of EMRs now, if you're in a smaller facility, they might not have been collecting that information. Or what I would often see was it was all listed as unknown because you're registering someone really fast and you put unknown in. So therefore, your information that you're trying to associate with something is not there. Is that kind of what you're talking about?
Yeah, I mean, it's not there in your data set, right? It's not there in Blue Cross.
It's not there in a lot of places.
Like the previous speaker said, surely I've entered this, and surely we have somewhere.
Somewhere, yes.
I was wondering if those partnerships were about getting to the data that was needed to drive this analysis.
It's getting better. And I will tell you that Kanza has also, I don't know if you've all heard of Kanza, but they are they share information with a lot of different facilities, different avenues of healthcare. And they've really focused on some of that information as well. And they're helping collect some of that. Because you're getting it from so many different places. So what's happening when you combine all this information, you have different, you might have somebody saying they were Hispanic, and on another piece of information, you might be saying that that's not the case. So then which one is the source of truth, is what I'm saying. But when you can actually identify it yourself, then we're seeing that that's where our information is matching up more. Now, partnership-wise, I think that's coming down the pipelines from a lot of different areas because it's being required now. And you're seeing this from different measures that they're implementing that are required. So we're hoping to see that just get better and better as we go. Did that answer any of that? Okay, very good. Another requirement is drills and exercises, and you don't think about that, but especially when you're in rural America, you need to know that when this particular situation happens, this is what the response is going to be. And you're not good at that unless you're practicing that. So, well, as I said, it's nationally consistent for evaluating quality and value of care. And there's lots of national alignment with it, like Sonia said, Health and Human Services, American College of Gynecologists, Maternal Health. Is anybody here today that's part of the Kansas Collaborative? No? They are an amazing, amazing group. They hold meetings pretty regularly, and we encourage anybody that's in a facility setting to really plug into those because it gives you a lot of data connections, I should say, as in resources and connections and collaboration. So when we looked at the distinction centers in Kansas, you can see the listing of them. Those would be ones that are on our website. I compiled this list and compared it to the ones we had before. And so my focus ended up being who had it before and who lost it, and why don't they have it again, like I had said. So after I compiled all that information, I was able then to go in specifically and do some outreach with our facilities through our representatives and through Sonia, and we were able to see if they had any interest in being part of a quality care initiative so that we could get them back on with their Blue Distinction Center. So we identified at least 3 of them right away. And then we had 2 takers, and one kind of didn't think that they were at the right place to do that yet, which is fine. But that's what I want to tell all of you. Share it with your friends if this is of any interest to you. Because whether or not you're going to get that Blue Distinction Center certificate that year, that day, that's not really where we focused this project. We focused the project on improvement. Improvement in even just one area. So if people wanted to follow along and work together with us, I know people don't always have that time, but that's where we took that burden off of those people. I was looking at their data. I was saying, this is where we should focus. They wrote up their quality initiatives, and then they reported back when that had been met. And we have 2 of them that very quickly were able to reobtain the certification. And I'm still looking for my 3rd one. And my goal was by the end of this year that I'd have a 3rd facility. So if you know of anybody interested in that, or your communities would benefit, or you think you have a great community and a great center that should have this, then definitely be in touch with Sonia and Virginia. And I like to say that I'm just kind of the stair step in the between, because nothing's better than to be able to have someone that you're talking to that's done it before and who can give you that information, and you can talk from a medical perspective as well. So I kind of talked about this a little bit. We did quality improvement plans, and then we reviewed monthly, and we wanted to increase our facilities from 13 to 16. Now, the next thing I want to look at also, and I don't have that here to present, but I want to go back and look and see if I can find information in general from the association that shows how other states are doing this. Because I think that would tell us something. I think it's pretty good to have 13 and hopefully 16. I have no doubt we can have even more. So yeah, this is where I kind of came in, the on-staff nurse with OB/GYN experience. I just think that's very important when we're talking about specialties, whether it be the spine, the hip, the knee, maternal factors, I think is very important. When they redid all the criteria at the association, they looked at a lot of the AIM criteria, and that's best practice. And so they started implementing and saying, we're going to require what's best practice, because there's so much more that's come along that wasn't implemented before. We need to keep up with that. And that's where I found a lot of people struggling. So the data that I did compile, I was finding that they were low in the trauma-informed care and educating on that. And then, what was one of the other ones? I'm trying to think. I can't believe I blanked out on that. Cesarean section, is it here? So when I got the 2 that we got, it was Newton Medical Center and Neosho. Neosho did theirs very, very quickly. They had a quality department working on that, and Newton did not too much further after them. And they also have a quality department. But what I think is really important and pivotal is to get the right teams lined up. Because you can't just say, put it on the quality perspective lap, because there's also quality within quality. There's quality in these departments, and there's the right people that have to make it happen. And that's why I'm so passionate about this, because I was a nurse that was in there trying to make things better. And so if you give some of that to people to take that responsibility for, they're going to decide to own that in a different way. And so if you can get them on board, that's going to drive your results. So this is actually the community I'm from, and I had nothing to do with them getting it. It just helped facilitate and help them guide them through. Because once they had met those, they were reapplying, and then they both came back with certification. So when we talk about partnerships and collaborations, we want to talk about anything in these communities that would help them achieve that success. Because it's not done by just one person. It's done by a group of people. It's done collaboratively. And that's why this conference to me is so exciting. So I would coordinate. They had a lot, different departments are so busy. So if I couldn't reach or get in touch with the quality person, I knew I could get in touch with maybe somebody who's heading up or part of the actual department. And that's where I think misalignment happens a lot. Because unless they're really together and in tune with each other, you're gonna get different stories and different information and different data. Because some of their data was being pulled by an analytics department, and then some of it was being looked at on their floor, and then some of it was being looked at from quality perspective. And so when you're trying to figure out who's not part of a denominator and who is in the numerator, you have to decide what you're looking at. And you have to all be on the same page with that. Because otherwise, you're going to have different things going into your survey that might not be accurate. So what happened was, it was kind of interesting, because I don't think it started this way. It started as, who's going to do this? And I didn't know. I didn't have the letter. I didn't know that this program was being worked on. But when you want to make a change and you want to participate in that change, you just never know what's going to happen. And I feel so blessed that I got to speak up and say, I have interest in this area, because then I was able to work with these facilities and with Sonia and with the data analytics department. And when you can see all this data, that's what drives your initiatives. It wasn't very hard. It feels like I'm not talking rocket science, because it's not. Because I was just talking with someone today about that. I don't feel like I'm really talking about, all of the analytics that goes into it. It's about compiling those analytics, and that is the hard part, yes. But then when you look at it, you can really see. You can make very simple charts, really, to be able to drive that, because you can say, well, who had this last time? Who doesn't have it now? And then ask those questions of why. And that's really got me those three pretty quickly. We made templates. The association provided us with a lot of information. But if the facility has something already established, work with that. Like Sonia and Virginia both said, we don't have to reinvent the wheel. It's just about working with people together and coming up with a plan. Like I said, there were challenges, and I think if they could have the accreditation, I bet you on a buck there's like 3 or 4 more that we could have reapply and have that accreditation, or have that certificate. So that is challenging for some of the smaller facilities. And staffing smaller facilities, they might not have the staff, because sometimes you wear 5, 6 different hats. And then newest best practice, I kind of talked about that. They can be challenging to learn and adopt. One of the things is not a criteria, but it is something that's on there, and it's, do you support nurse midwives? Do you support doulas? And everybody has their place. So I think it's really important to look at it from a holistic perspective, like we've all been talking today. Sorry. And really determine where everybody's piece of the fits into the big holistic puzzle. Because once you get those people all in the right places, that's when you're going to have the outcomes that you can look and analyze again and see that they have decreased and things have improved, just from those adjustments that you made in your plan when you're trying to achieve something like a designation. Oh, let's see, yeah. I think that's, yeah, the last one. It was the trauma-informed model of care that was the big challenge. Oh, and proper identification through ethnicity and race that people were having a challenge on. A lot of the health information EMRs out there, there is an unknown. So when you can mark unknown, not ask, then you don't have to mark anything else. So then you don't have the information that you need.
And then go forward one more slide. There's our email addresses if anyone would like to get in contact with us.
So if anybody's interested in any kind of specialty designation for your communities or facilities, we're happy to even just talk. It doesn't mean we have to say, you have to do this. It could just be a conversation. So if anybody's interested, please reach out, or if you know of any facilities and you can make that recommendation to them, we'd be happy to visit with them. Thank you.